presentation on the knee examination. I hope you find it helpful. We're going to do a quick revision of the anatomy of the knee. Then we're going to go through the different stages of the examination of the knee, including inspection, palpation, movements of the knee, both active and passive, and then some special tests looking at the collateral ligaments around the side of the knee, cruciate ligaments inside of the knee joint, the patellar apprehension test looking for patellar instability, and finally the spongy meniscus. How do we test for that? So the knee joint is a synovial joint between the femur and the tibia. You have various ligaments inside and outside of the knee holding the knee joint together. On the tibia you have the medial and lateral meniscus that are like spongy cushions. They can tear and lock the knee. You also have the anterior and posterior cruciate ligaments that also give a lot of strength internally to the knee, and if they snap or tear, then you have a lot of laxity in the knee joint. Around the knee you have the lateral and medial collateral ligaments that hold it on the lateral and medial borders. Remember that this is a joint between the tibia and the femur. The fibula does not actually articulate with the knee joint directly. Also, around the knee joint you have various bursa. You have a prepatellar bursa and infrapatellar bursa that often become inflamed, particularly if people do activities of kneeling down on the knee. It's one of the main causes of anterior knee pain, prepatellar or infrapatellar bursitis. So people who pray, used to be called clergyman or parson's knee in the UK. I guess anybody who does salat, it's a risk factor, and it's difficult for men or women to pray if they have an inflamed bursa. Also, don't forget the patella. The quadriceps goes through the patella, the tendon, and the patellar tendon inserts just over the tibial tuberosity. So this is often a sign we get pain in Osgood-Schlatter's syndrome. Just a reminder of the many different causes of knee pain. It can be divided into anterior knee pain, just mentioned Osgood-Schlatter's disease in teenagers. You can get inflammation of tendinitis of the patellar tendon, often associated with jumpers who maybe use trampolines. I already mentioned bursitis, and more a diagnosis of exclusion, once you've excluded other causes of anterior knee pain, chondromalacia patella, now called patellofemoral syndrome. This can be beginnings in osteoarthritis. Also in young women are more prone to patellofemoral syndrome. Within the joint itself, obviously you can get, it's a synovial joint, you can get osteoarthritis or rheumatoid arthritis and other inflammatory arthritic problems like gout or cirrhotic arthropathy. Again, we've mentioned anterior and posterior cruciate ligament tears, meniscus tears, all can contribute to pain inside the knee, can cause locking and the feeling of giving way if particularly the cruciate tear has occurred. Don't forget fractures, whether hairline or severe in the patella, tibia or femur. Around the joint and posteriorly in the popliteal fossa you can have a Baker's cyst. Also either medial or lateral you can have a collateral ligament sprain. Often this is a sport injury like a side tackle in football. And then always remember, with any joint in the body, think above the joint and below the joint. So could this be referred pain from the hip? In children this could be a slipped upper femoral epiphysis, or in adults, osteoarthritis of the hip. It could also be iliotibial band syndrome, pain coming from the greater trochanter down the side to the knee, particularly in runners who may be doing a lot of road running. And also ankle or foot pain can radiate or be referred up to the knee too, particularly tendonitis from muscles in the lower leg. So once we've gained consent, washed our hands, maintained privacy, and got exposure of both the knees, you want exposure above the knee joint itself, the patella, and be able to see the quadriceps. You're going to look for scars. In the picture on the right, you can see 3 scars around the knee where the patient's had an arthroscopy, and then a midline scar too. It's likely they've had an ACL or a PCL repair. More likely to be anterior due to the scar in the midline. Also look for any rashes. You can see the top right, psoriatic rash, so you begin to think about psoriatic arthroscopy. Look for any inflammation. That could be infection, it could be an inflammatory arthritis. Look for swelling. You can get very localized swelling anteriorly, bursitis, or more global joint effusion. Then have like what's called a horseshoe effect over the top of the knee superiorly. There's a photo looking at a normal compared to the left knee, the joint effusion. And then don't forget to look at the back of the knee in the popliteal fossa for a Baker's cyst, as is present on the patient's left knee in the photo. So now we're going to look at inspection in terms of the posture and integrity of the knee joint. One thing you want to do is ask the patient to stand up and actually walk the patient. Look at the gait. Are they doing a proper heel strike, or are they toe walking? Is there evidence of a fixed flexion where they cannot fully extend the knee, and they're walking with a limp? We talk about the posture of the knee in terms of whether there's a genovarum, where the knee joint is abducted and externally rotated, or is a genovalgum, where the knee joint is adducted and internally rotated. The genovarum, you may get that with rickets. The genovalgum, you may get that with paralysis of the nerve or muscle wasting. And that's what you're going to look for as well. That's why you want to expose the quadriceps to compare both quadriceps. Is the wasting compared to one side to the other? Here you see the diagram in the bottom right. The left leg has obvious quadriceps wasting. One of the causes of a fixed flexion deformity is the bucket toe of the meniscus, and that locks the knee and makes it impossible for the patient to fully extend the knee. Now we're moving on to palpation. You want to check for warmth in the joints, is there any inflammation or infection. Use the back of your hands and just compare both knees for temperature. Check for synovitis by pressing posterior to the patellar tendon on either side of the tendon. You get like a sponginess, a bouncy feel, and a tenderness with that. Then flex the knee to 90 degrees and move your finger along the joint lines both medially and laterally, pressing in to see if there's any tenderness. This could be due to osteoarthritis or a collateral ligament sprain or a meniscus. With anterior knee pain, you want to palpate around the different bursa, but also palpate the tibial tuberosity, because this is the site where the patellar tendon inserts and is where you get the Osgood-Schlatter's disease occurring. Another aspect of palpation is assessing for a joint effusion. If you're looking at the right knee, I tend to use the left hand, squeeze the quadriceps, bring your hand slowly down to the patella. So you're milking the fluid down into the joint. Holding your left hand in that position, I then tap on the patella, and you'll feel the patella hit the femur behind if there's fluid, and it'll bounce back up. Keeping your left hand in that position, you can sweep the lateral border of the patella, and you might notice a bulge on the other side as you push fluid across. You can repeat the process on the medial side. Sweep your hand from inferior to superior direction, and as you sweep the fluid, you can push the fluid across and see it bulge on the other side of the patella. And this is a joint effusion that you're assessing for. So then we get to the movements. You want to ask the patient in a supine position to actively flex the knee to the full extent they can and fully extend the knee. Normal range is from 0 to 140 degrees. Now you're going to get involved in passive flexion and see if you can move the knee any further. You want to also just check if it's fixed flexion, if you can fully extend the knee or not. And particularly with younger people, there may be some degree of hyperextension. Up to minus 10 degrees is normal, but beyond that, that is unusual. One thing I tend to do with them flexing the knee is put my left hand, if it's the right knee, just over the patella and tibia, and feel whether there's any crackly sensation under my palm, what we call crepitus. And this can be present in patellofemoral arthritis, and it can be a sign of osteoarthritis in the knee. One other thing you'll do is just ask the patient to keep the leg extended, lifted off the bed. Now, if the patient can't maintain this and the knee begins to flex, it's likely they've got some quadriceps muscle weakness. Now we move on to the special tests. When looking at the collateral ligament, should I say, we keep the knee in full extension. You can repeat this at 30 degrees if you're looking for minor laxity. You want to hold the ankle with your arm pushed into your side. And then you're going to apply a valgus force and then a varus force to the knee, testing both the medial and collateral ligaments. You're looking for any pain and laxity too in that varus and valgus directions. Looking at the cruciate ligaments, you want to flex both knees to 45 degrees together and look across from a lateral view to see if there's any subluxation of the tibia. Is there a sag? And this may be due to a tear of the posterior cruciate ligament, the PCL. The anterior draw test is where you keep the knees flexed at 45 degrees. You're going to sit on the patient's foot with their permission to stabilize the leg, check the hamstrings are relaxed, wrap your hands around the upper tibia and thumbs resting on the tibial tuberosity, and then draw the tibia anteriorly to check for laxity. And if that movement is more than 1.5 centimeters, you usually get quite a lot of resistance in that movement, and then there may be some laxity or a tear of the anterior cruciate ligament. The posterior draw test, same as above, but this time I'm going to push the tibia backwards. I use my heel of my hands to push the tibia back and check for any laxity. Moving on to the testing of the patellar stability. In this, we're looking for any instability or dislocation of patella. So in this test, keep the knee fully extended and push the patella laterally using my thumb, and then begin to flex the knee slowly, keeping the pressure on laterally with my thumb. If the patient starts resisting flexion, maybe there's a sign of instability or dislocation of the patella itself. So now we're going to look at the meniscus. How do we test for that if there's been a tear or a disruption? The commonly used McMurray's test is where we're going to provocate the meniscus. When looking at the medial meniscus, we want to passively fully flex the knee and then externally rotate the foot and abduct the upper leg at the hip, keeping the foot towards the midline. So that puts stress and strain on the medial meniscus. With the lateral meniscus, again we fully flex the knee, but this time we're going to internally rotate the foot and adduct the leg at the hip. And that's going to put pressure on the lateral meniscus. You may feel a positive clunk or click accompanied by discomfort by the patient, and that's a positive sign. I prefer Apley's grind test. It's an alternative to McMurray's. It's actually more sensitive and specific in terms of picking up a meniscal injury. In this test, you're going to put the patient in the prone position with the knee flexed at 90 degrees. You put your knee on the patient's thigh to immobilize their upper leg, and then rotate the tibia laterally and medially. First with distraction, lifting up the tibia, and then with compression, where you put a downward pressure downwards through the heel of the foot as you rotate, both medially and laterally. And a positive test is when there's more pain with the compression aspect of the test, and you also may notice reduced rotation. Again, the patient may be in some discomfort, and usually acknowledge that. Also, I like this test because I can look at the posterior aspect of the knee, look for any popliteal swelling like a Baker's cyst. Finally, it's worth doing a squat test, looking for the integrity of the posterior horn of the meniscus. You can repeat squats. You can also ask the patient to point the feet in and then out, stressing the different menisci, whether medial or lateral. And again, you're looking for pain or unable to maintain the squat due to laxity of the meniscus. Thank you for listening. I hope this was useful. I'd recommend McLeod's, both the video and the book, for further detail.